This recording is going to cover the last part of the autonomic nervous system. We're going to start just talking about interactions between both divisions of the autonomic nervous system. I'll also talk about some clinical correlations, some use of some clinical conditions, and some drugs that affect the various receptors that are part of the autonomic nervous system. Your sympathetic and parasympathetic divisions of the autonomic nervous system are active to some extent all the time. Both of them are active, but generally like where we have structures that have innervation by both is you have innervation by both the sympathetic and parasympathetic branches. It's just which is more dominant at a certain, which is more active, which ends up getting what you want. So for example, if we talk about the heart is innervated by the vagus nerve, which carries parasympathetic fibers, which is cranial nerve 10, and it also is innervated by sympathetic nerve fibers. Now the having both innervation is very important for precise control, but when you're in like a fight or flight mode, you're going to have more sympathetic, so you're going to have a higher heart rate, higher contractility, and therefore higher stroke volume. When you're in rest or digest mode, you're going to have more of the vagal stimulation. And remember, the vagus releases acetylcholine and binds to muscarinic receptors, and its primarily action is by decreasing heart rate. Now, another place that we have dual innervation, but actually before I do that, I do want to talk about some structures that have no parasympathetic innervation. They're innervated by the sympathetic division only, and the ones that are important for you to remember are the ones that I've done in red. Now remember, this is actually a pretty important one, that the sweat glands are innervated by the sympathetic division of the autonomic nervous system, but the fibers that are in that nerve, and the nerves involved, actually are cholinergic, which means they release acetylcholine. So this is kind of a weird one, is that it does release acetylcholine. And when you're in sympathetic mode, you're going to have increased sympathetic activity, and therefore you're going to sweat more. The erector pili muscle, which causes piloerection of the hairs to stand on end, that's sympathetic innervation only. Your adrenal medulla, we had mentioned, is actually a modified sympathetic ganglion. It releases epinephrine and norepinephrine into the bloodstream when you're in sympathetic mode. And most of your blood vessels are just innervated by the sympathetic. So what happens with that is by changing the activity, the firing rate from those nerves will determine if the blood vessels are dilated or constricted. So if you have an increased firing rate, you're going to have vasoconstriction, which you see here. And again, the alpha-1 adrenergic receptors are located on the smooth muscle of those blood vessels. If you have less firing, then the muscle relaxes and you get the vasodilation. So those are some structures that just have innervation by the sympathetic division. Now we do have very close interaction between the sympathetic and parasympathetic divisions in your reproductive organs. Specifically, I'm going to use the example of the penis in the male. Now the parasympathetic division is extremely important in releasing substances that lead to the erection of the penis, the increased blood flow to the penis. So the parasympathetic branch is extremely important in the development of the erection, and the sympathetic division, though, becomes important when you have emission and ejaculation. So emission is that movement of the sperm and the different fluids through the male reproductive tract, and ejaculation is actually where it exits the male reproductive tract. So you start off with being parasympathetic division, that's important, but then you switch to sympathetic during emission and ejaculation. Now, what I want to do is talk about some medications. Now, I had mentioned previously that both divisions are active to some extent all the time, and we do have medications or drugs that can enhance the activity of one by either stimulating or inhibiting the activity of the other. And a lot of medications target the adrenergic receptors that we have for the sympathetic division of the ANS. And that's why it's important that you know actually the specific types like alpha 1, beta 1, beta 2. And I've had many students that have worked in for pharmacies, and they say, yes, we do have to know the various adrenergic receptors. Now, the muscarinic receptors, we do have M1, M2, M3. You have different subtypes of those, but you usually don't have to know those. So do not worry about knowing the subtypes of the muscarinic. Just know if they're a muscarinic receptor. And we do have medications for that target the muscarinic receptor. Now, if I use a term antagonist, another term they use is a blocker, what I'm referring to, so if this say is a receptor, and we'll say it's supposed to bind norepinephrine. If I have a medication that's actually a receptor antagonist, I have a medication that will bind to it, but actually block norepinephrine from binding to it, and it will not be able to be stimulated by norepinephrine. So those are antagonists. Now, the effects of those, because they inhibit the normal neurotransmitter from binding to it, or in the case of hormones released by the adrenal medulla, which would be norepinephrine or epinephrine, is what you would have is the opposite effect of what you would expect with that neurotransmitter binding. So, for example, lopressine is a specific beta-1 adrenergic receptor blocker. It's a beta-1 adrenergic receptor antagonist. Beta-1 adrenergic receptors are located in the heart. And typically, norepinephrine will bind to that receptor in the heart and increase heart rate and contractility. With the beta-1 adrenergic receptor blocker, what happens is heart rate decreases and contractility decreases, so I'll write stroke volume. End up result is stroke volume decrease. So that's specific for the beta-1 adrenergic receptor. Now, we do have some non-selective beta blockers like Indrol. Well, that means it can bind to, say, the beta-1 as well as the beta-2 receptor. And where that could become a problem, it's often given for the same reasons as lopressine is given to people, because often it's used for, say, blood pressure, to regulate blood pressure, is this because it can bind also to the beta-2 adrenergic receptor. If you review your notes, in the bronchial smooth muscle, you have beta-2 adrenergic receptors. And when norepinephrine binds to that, it causes relaxation of it, causes bronchodilation. But if you give someone Indrol, it actually would cause some mild bronchoconstriction. Now, this can become an issue with people who have, say, asthma. They have issues to begin with. So if you have an asthmatic and they need it to be taken a beta blocker, they're going to give them a specific, the beta-1. They're not going to give them Indrol because that would cause more issues with them breathing. There is a difference in price. So if you can get away with doing Indrol, they're going to give it to you. But if you need lopressine, they'll give it to you, but it costs a lot more. So what you'll notice is with the blocker, it has the opposite effect of what you expect. Now, if I use the term agonist, agonists say, and I'll leave, before I go to the muscarinic, I'll do so here say an adrenergic receptor agonist, or a receptor, and the agonist would bind to that receptor, but it actually would do the same thing as the neurotransmitter would do. It would stimulate that receptor, so it would have the same effect as if the neurotransmitter was binding to it. So a beta adrenergic receptor agonist would increase heart rate, or because if it binds to the beta-1 adrenergic receptor. If it bound to the beta-2 adrenergic receptor, it would cause bronchodilation. Okay, so agonists have the same effects as if the normal thing that bound to that receptor would. Now, we do have some muscarinic receptor agonists as well as antagonists. So pilocarpine is a muscarinic receptor agonist, and that would do the same effects as if acetylcholine bound to the receptor. This could be used, for example, if someone has what we call paroxysmal tachycardia. Is pilocarpine, being a muscarinic receptor agonist, would cause a decrease in your heart rate because you have the muscarinic receptor on the heart, and the end result is a decrease in heart rate. A muscarinic receptor antagonist would have the opposite effect, and atropine is an example of a muscarinic receptor antagonist. That would, because it binds to the muscarinic receptor and keeps acetylcholine from binding to it, that would actually result in technically an increase in heart rate. Okay, so that's not typically administered for that, but they usually use something like atropine for eye exams. It does also would decrease salivation, but it can be actually is an antidote for treatment of something called cholinergic syndrome, and I'm going to be mentioning that. Where if there is a instance where the person is releasing an excessive amount of acetylcholine to their system, or they've been given a medication that causes excessive activity of acetylcholine, is actually it can be used to block that receptor. So it's an antidote for this, something called cholinergic syndrome, which can be a result of organophosphate poisoning, ingestion of certain types of mushrooms that could also, and we're going to use the example to kind of review what the muscarinic receptors do. Some clinical conditions before I go over an example of a clinical condition other than that's a result of poisoning is all these four that I have listed are actual examples of things that affect the sympathetic nervous system. Orthostatic hypotension is a condition where people, if they change their body position, going from lying down to standing up, is most of us, we have a very pretty good baroreceptor reflex, which allows us to maintain our blood pressure. Because when you stand up, initially your blood pressure drops, but that reflex is so quick that it causes your heart rate to increase, your blood vessels to constrict to maintain an adequate blood pressure. But if that's there's a problem with it, is they'll have low blood pressure when they change their body position. So it's typically an issue with problems with the sympathetic nervous system. Raynaud's phenomenon, you see here in this is actually one of my former students, is if you notice her fingers right here, very, very pale. She was very, very sensitive to the cold, and it caused significant vasoconstriction to the blood vessels and her digits and her fingers and her toes. And so her fingers would get very, very cold, white. She'd have to wear gloves all the time. People with Raynaud's phenomena, they have very, very sensitive to the cold. And so they have an excessive sympathetic response. And in this case, it's to the blood vessels. You get significant vasoconstriction to the skin of your extremities. Ulcers can result of excessive sympathetic because ulcers tend to decrease the production of mucus in the gastrointestinal tract, which with less mucus, you're more prone for the development of ulcers along the GI tract. High blood pressure, hypertension, there's a number of different causes of hypertension, but one of them is people with just excessive sympathetic stimulation because that will affect your blood pressure. Now, one of the things I do want to mention is just this clinical condition, and you see this little mnemonic, dumbbells, and this is these are signs and symptoms of people with referred to as cholinergic syndrome, or you may actually also hear it as cholinergic toxidrome. So organophosphate poisoning, eating certain mushrooms they weren't supposed to eat, not supposed to go out, unless you're absolutely sure what that mushroom is, you be careful about what you eat, is this dumbbells helps to kind of remind us of some of the signs and symptoms associated with this. But I'm doing it is to review with you the different effects of acetylcholine on target structures. So here we have an excessive amount of acetylcholine. So acetylcholine, for the most part, think parasympathetic nervous system, it increases motility and secretions along the GI tract. So that explains the diarrhea. It's important for that rest and digest, and when you urinate, you need to be in that rest and digest mode. So it's important in that relaxation of the internal urethral sphincter muscle, contractions of the bladder. So that explains the urination. Meiosis is where you have excessive constriction of the pupils. And remember, the pupillary constrictor muscle of the iris is innervated by parasympathetic fibers coming from the oculomotor nerve, and you can get excessive constriction there. It does cause, when you're in rest and digest mode, you do have constriction of your pupils. Bradycardia is a heart rate less than 60 beats per minute, and acetylcholine binds some muscarinic receptors on the heart, and it lowers your heart rate. And I'm going to put a star by this one. And I'm going to put a star by this one. These are the two reasons why you usually could die as a result of this, because if your heart rate gets too low, you're not able to get enough blood out to your organs, and you can die as a result of it. Bronchospasm, the inability to be able to get air into your lungs because you have significant bronchoconstriction, because muscarinic receptors, the effects of acetylcholine bind to the bronchial smooth muscle, is bronchoconstriction. So that explains that. Emesis is where you're throwing up. That one we're just going to skip because that's harder to explain, even for me. Now, lacrimation, so your excessive tear production. So the lacrimal glands, which are innervated by your facial nerve, and that has, again, muscarinic receptors, and the result of that is to increase tear production. So lacrimation is increased. Lethargy, that's kind of where you're just kind of weak, don't have a lot of energy. That's actually has nothing to do with the ANS. This one actually has a relationship between acetylcholine and its effects on skeletal muscle. Acetylcholine is the neurotransmitter released by somatic nerve fibers, and that binds to a nicotinic receptor on skeletal muscle and actually does lead to kind of excessive contractions, but that can lead to kind of being tired out. So, don't worry about that because we'll talk about that much later. Now, the last two, kind of put them together, sweating and salivation. I'll do salivation first because, again, that's an association with the parasympathetic nervous system. So acetylcholine binds to muscarinic receptors on your salivary glands. So you have innervation by your glossopharyngeal nerve as well as your facial nerve to the salivary glands, and you have increased salivation. And make sure you remember the ganglion that are involved. So you had otic ganglion that was associated with the parotid salivary gland, and you had the submandibular ganglion, and that is innervates the sublingual and the submandibular salivary glands. Otic ganglion is associated with the glossopharyngeal nerve, and the submandibular ganglion is associated with your facial nerve. Now, the last one is kind of the odd man out. This still is an effect of acetylcholine, but this is acetylcholine binding to a muscarinic receptor on the sweat glands. But remember, this is something that's associated with the sympathetic nervous system. But remember, these are conditions associated with excessive acetylcholine, and acetylcholine is the neurotransmitter involved in sweating. So you do have increased sweating. So these are all signs and symptoms associated with you have excessive acetylcholine. So what is the antidote? Well, atropine, because that's a muscarinic receptor antagonist. So that would block the effects of atropine on that. So what would happen if I have an overdose of atropine? So this is a little saying that they say for it. You're hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. And what you see here would be a result of not having acetylcholine be able to bind to the receptor. And so if you can't sweat, you can have an increased body temperature. You get dilated pupils, vision becomes blurry, and then you can just read the other one. So this could happen if you have an overdose of a muscarinic receptor antagonist, because you have the opposite effects of what you'd expect with acetylcholine. So I just wanted to show you that. But this one is a good one to review, because it really does go over, reviews with you the acetylcholine's effects on certain target organs. It's very, very important that you review your the receptors that are located in certain targets. So if I ask you a question about what would be the effect of a, say, muscarinic receptor agonist on a particular organ, or antagonist, or beta or alpha-1 receptor agonist, that you could answer the question. So remember, you have to know what receptor is located on that target. Then if I give you an agonist, it would have the same effect as I've given you before. If I administered an antagonist, it would have the opposite effect. So review that, because you will get some questions on your exam that cover that.